The camera is yours.
The screen and the camera are mine. Thank you so much. Jose, that was it was really nice to be introduced by you. It's really exciting to be here with this group today. I have a standing Friday conflict that has made it really difficult for me to be able to attend these, but my heart is here, and actually I moved things around to make it work for this week, and it's opened my mind to the possibility that maybe I should just move this so I can always make this. So thank you. I hope to be back more often because I really look up to, and in some cases have been directly mentored by people that are here today, and it means a lot to be invited to come speak. So I'm going to go ahead and share my screen. All right, someone just give me a thumbs up. Everything on the screen and looking good.
Yes, good.
Thank you. So the title of my presentation is mapped closely to my K23 award that I was awarded in July of 2018. And that is Enhancing Primary Care-Based Treatment for Opioid Use Disorder. And I have no conflicts of interest to disclose, and would really like to acknowledge the generous funding that I've gotten, including from NIDA. And my goal for today's presentation is really the goal of my 5-year K, and that is to really highlight the extent to which children and adolescents and young adults have not been spared from the rise in morbidity and mortality attributable to opioids. And so the 3 aims of this presentation for the next hour are really meant to map onto the 3 aims of my K. First of all, to quantify receipt of addiction treatment and retention and care among youth with opioid use disorder. 2, to list common facilitators and barriers to receipt of addiction treatment from the perspective of clinicians, youth, and family members. And then 3, to describe some approaches to improving clinical services for youth with opioid use disorder. So just by way of background, I think it's pretty clear to everybody in this group, but it's not always clear to people from other places or other groups that morbidity and mortality from OUD is rising among youth. And in fact, retention and care is one of the strongest predictors of decreased mortality among adults. And we know that retention is enhanced among adults who receive opioid use disorders medications such as buprenorphine, naltrexone, and methadone. And sort of coming into my K, we really were lacking data on retention for youth, particularly beyond 3 months of follow-up and from real world settings. We've got fantastic studies, again, by some of the folks that have led seminal clinical trials who are here today, including Dr. Woody and Dr. Marsh. To complement that, my K really sought as its first aim to sort of build out and look to see what happens sort of as we go further out in follow-up and what's happening out in the real world outside of clinical trial settings. Multiple organizations recommend providing youth with buprenorphine, naltrexone, or methadone. And yet we know that youth are only 1/10 as likely as adults to receive an OUD medication. Reasons for this include poor availability of prescribers who are focused on youth, discomfort among providers in prescribing to youth, and stigma often coming from youth, family, the community, and providers themselves surrounding use of OUD medications. And in fact, we know that many drug treatment programs actually deny entry to youth who are on OUD medications, or might actually discontinue OUD medications on admission when youth come to them already on them. And so this sort of sea of factors is what really led me in my K23 to try to understand, first of all, the extent to which youth are engaged and retained in addiction treatment, including standard of care treatment with opioid use disorder medications. And then 2, to understand the ways in which youth and families think that we can improve retention and care for this population. And then 3, to actually implement some of those changes in a clinical setting to understand the extent to which we can improve retention and care. And so this was really sort of the crux of my K23 was to understand the current landscape of retention and care and how we can improve it. And so the 3 aims, as I said earlier, really were these. 1, to quantify current standards of retention and care among youth receiving outpatient opioid use disorder treatment. Two, to identify and incorporate necessary modifications of the OBOT intervention for youth, and I'll talk about that in a second. And three, to conduct a single arm adaptive pilot study of an enhanced OBOT model for youth. So just lest I go too far into this presentation without talking about what OBOT is. OBOT is, for those not familiar, office-based opioid treatment, and it's a national and nationally recognized model of opioid use disorder treatment, first developed for adults. And basically, it is a primary care-based treatment program in which people with opioid use disorder come to see their primary care doctor, and addiction treatment is provided right there in primary care. I'm a primary care pediatrician, so this model really speaks to my heart. What's tricky about addiction treatment in primary care is that there's a lot of sort of work that needs to be done that not always is easy for a general practitioner to do. You know, if you are providing, for example, buprenorphine to a person with opioid use disorder in primary care, you may need to make sure that they're seen really frequently, which a busy schedule might not sort of allow for. You need to make sure that they're providing urine drug testing sort of in sort of alignment with the national expectations around buprenorphine prescribing. You need to make sure that they have somebody that they can reach out to when there are issues with prescriptions. You sort of need someone who can help manage all the prescriptions and understand who's due for what and when, and sort of do some of this population management work. And so there was a recognition that this was going to be really tough work for general doctors to do without some support. And so the OBOT treatment model, the office-based opioid treatment model, really leans heavily on nurses operating at the top of their licenses to be able to do a lot of this work. So nurses will actually reach out to and engage patients. Nurses will actually be the ones who will do a lot of the follow-up with patients. Nurses will obtain and interpret urine drug testing, and nurses will help sort of tee up prescriptions for physicians and make sure that, you know, proper overdose training is provided to patients. And so I really liked this as a model for how we can improve addiction treatment delivery in primary care, and really built my K23 around it. A lot of the model's sort of development and implementation and then dissemination across the country originated at Boston Medical Center, where I trained. And where I'm currently a faculty member. And so this was really sort of, again, a convenient model because I had mentors to turn to in this work. But this model had never been sort of implemented in youth. And so we had a lot of sort of formative work to do. Again, this serving as a crux for my K to study and understand what work needed to be done. So I'll talk now about the first aim of my K, which is now complete. And this was really around quantifying current retention and care among youth, getting outpatient treatment for opioid use disorder. So what we did is we used the Truven IBN Watson health market scan Medicaid data, which included at this time data from 11 de-identified states. We looked at data from the years 2014 to 2015, and we studied 2.5 million publicly insured 13 to 22-year-olds. This included all inpatient, outpatient, and emergency department and pharmacy claims for youth, and also included, just to be clear, behavioral health claims from all levels of care and procedure codes for medications that are often administered in clinical settings. So naltrexone and methadone, for example, are not typically or not always prescribed to patients for the treatment of opioid use disorder. In fact, they're often directly administered in a clinical setting. And this is just to highlight that we were able to study this particular scenario in this database. Within this large sample of 2.5 million youth, we identified youth who were initiating new episode of care for opioid use disorder, which we defined as a diagnosis of opioid use disorder using previously studied diagnosis codes in at least 2 outpatient or at least 1 inpatient or emergency department encounter, and ensured that all youth had at least a 60-day period without an opioid use disorder diagnosis or receipt of medications sort of preceding that. And then using this approach, we're able to identify a sample of nearly 5,000 youth that were initiating a new episode of care for opioid use disorder. We then were interested in knowing about these 2 outcomes among those youth. First of all, what percent percentage of youth initiating care for opioid use disorder received what we called timely addiction treatment. And to us, we decided that timely would mean 3 months. We actually did some sensitivity analyses that I won't go into here that looked at different cutoffs, looked at within 1 month, within 2 months, within 3 months, within 6 months. I think many people would argue that 3 months is actually not timely, that when you have an opioid use disorder, you need treatment now and you can't wait 90 days. But this is what we studied in this particular paper. And we looked at receipt of behavioral health services at the outpatient, intensive outpatient, partial hospitalization, residential, or inpatient level, and or receipt of any of the 3 FDA-approved opioid use disorder medications, buprenorphine, naltrexone, or methadone. So that was sort of outcome number 1. It was an and or of behavioral health services with medication. And then the second outcome that we looked at in a subsequent part of the study was, once you were in treatment, how long were you retained in treatment? And we considered retention in treatment to be defined as ongoing receipt of either behavioral health services or of OUD medication without an interruption of 60 days or more. We were able to look at a lot of different covariates in our analyses. So we looked at the age of diagnosis, sex, race, and ethnicity of the individuals, the basis on which they had Medicaid eligibility, which for the vast majority of youth was based on low income. And then numerous clinical characteristics that I listed here at the right. We looked at multiple different psychiatric comorbidities. We looked at other substance use disorders. And then we looked at acute and chronic pain conditions, recognizing that these are often sort of wrapped up in an individual's opioid use disorder. And then in our analyses, we identified the percentage of youth receiving timely addiction treatment within 3 months of diagnosis, as I said. And then in a subsequent analysis, measured the association between receipt of medication and retention in care using the Kaplan-Meier method and survival analysis using multivariable Cox regression, adjusting for the covariates you see here. The idea here being that we wanted to understand the extent to which medications and their receipt were associated with retention in care. So just to give you a sense of the sample of youth that we studied, the median age was 20. Actually, a majority of youth that we studied were women or girls. And this actually led us to a subsequent spin-off study that actually Dr. Sarah Bagley just published a couple of months ago that I'd be happy to talk about, because we were surprised that most of the individuals in this sample were female. The majority of individuals were non-Hispanic white, but other races and ethnicities were represented. And then you can see that there was a pretty high prevalence of psychiatric comorbidity, as well as other substance use disorders and pain conditions. Overall in the sample, we found that 76% of youth who initiated care or started an episode of care for opioid use disorder received some form of treatment. But what we found is that the vast majority of youth who received treatment were getting behavioral health services. Actually, only about 1 in 3 received an opioid use disorder medication, with the vast majority receiving buprenorphine, which probably makes sense since buprenorphine is FDA approved for 16 and up, in large part, again, because of the clinical trials conducted by some of the people that are on today's call. When you broke it down by age and asked the question, by age, who got behavioral health services only versus who got medications, the x-axis here is different age clusters. And the y-axis is the percentage of people that got any treatment, but the blue portion of each bar is the percentage that got behavioral health services only without any medication. And the red part of the bar is the percentage that got a medication for opioid use disorder. And what you can see is that younger than age 18, very few people got medications for opioid use disorder. It was really only once it was above the age of 18 of a participant that we saw that their receipt of medications suddenly started to jump up. And in fact, under the age of 18, only about 1 in 20 youth, apologies, pardon me, received opioid use disorder medication, but above the age of 18, about 25% or 1 in 4 received an opioid use disorder medication, really showing that there was this sort of steep jump where people, teenagers below the age of 18 very rarely got medication, whereas those above 18 much more commonly got medication. But overall, not that many got medication. We then asked the question, do medications seem to be associated with retention and care? And this is the figure from the paper that was ultimately published in JAMA Pediatrics. And what you can see is that the x-axis here is time engaged in any form of addiction treatment. Again, that could be in behavioral health services or ongoing receipt of medication. And then the y-axis is the cumulative incidence, or sorry, cumulative sort of survival, in quotes here, I mean survival in the sense of remaining in treatment rather than sort of surviving from a mortality standpoint. You can see the cumulative percentage of individuals retained in treatment. And the two lines are quite different. Youth who got medications for their opioid use disorder were much more likely to be retained in treatment, whereas those who received behavioral health services only were less likely to be retained in treatment. And so this really showed that when youth get medications, they seem to be retained in treatment longer. And that actually matches up with the clinical trial data that, again, Dr. Marsh and others on this call have seen sort of in their own randomized clinical trials as well. And just to put some numbers to that, when you looked at receipt of behavioral health only, youth were typically only retained in care for 67 days. Whereas when youth got buprenorphine, naltrexone, or methadone, they were much more likely to be retained in care. And in fact, the adjusted hazard ratio for loss of follow-up was much lower. So basically a hazard ratio between 0 and 1 in our analyses here it means that they were retained in care longer because they were less likely to drop out of care. And after adjusting for all the other covariates in our study, you can see that youth receiving each of the different medications were much less likely to be lost to follow up. Some limitations here. Our analyses don't adjust for the severity of opioid use disorder, unfortunately. Adolescents may have had less severe opioid use disorder than young adults, and therefore they may have been less likely to go on medication because of that. And I would also say that selection into the cohort was actually likely associated with receipt of medications. I know that I, as a provider, when a patient is introduced to me who wants to start buprenorphine, I then code for opioid use disorder. And so selection into our study cohort may have actually been related to receipt of treatment. And so this might have resulted in higher proportions of youth receiving treatment and medications in analyses, almost certainly, in fact. And in fact, the true proportion receiving a medication was likely even lower due to underdiagnosis of opioid use disorder. And so the conclusions that come out of AIM-1 of my K23 are that only 31% of youth with opioid use disorder received a medication. And whereas 1 in 4 young adults over the age of 18 received a medication, only 1 in 20 adolescents under the age of 18 got one. And yet youth who got an opioid use disorder medication were more likely to be retained in care in these real world settings. So the implications of this are, in light of recent recommendations from the American Academy of Pediatrics, the American Society of Addiction Medicine, and actually as of last month, the Society for Adolescent Health and Medicine, we've got a lot of room to improve our delivery of opioid use disorder medications. Our findings really suggest that withholding opioid use disorder medications from youth may actually compromise their retention and care. So that was kind of a nice lead in to the second aim of my K, which is still ongoing and which is looking at some of the necessary modifications that we need to make to this OBOT model, this office-based opioid addiction treatment model that I talked about earlier, in order to improve primary care delivery of addiction treatment for youth. So in this part of our K, and I have this sort of like classic K setup of, AIM-1 is a secondary data analysis, AIM-2 is a qualitative study, and AIM-3 is an intervention of sorts. And so this is AIM-2, in which what we aimed to do was interview 12 to 15 youth to get their impressions of what changes we need to make in order to improve primary care-based delivery of addiction treatment for them. To date, we've recruited 14 and interviewed 14 at the time of this presentation. And so we may actually be close to completing recruitment. We have some ongoing analysis, as you'll see, to figure out if we've reached thematic saturation. We've also been interviewing caregivers. We have a goal of interviewing 12 to 15 caregivers. Unfortunately, here we've only been able to recruit 6 to date. It's actually been really tough to find caregivers who are heavily invested in the care of their youth with opioid use disorder, surprisingly, who are willing to be recruited for this interview. And we could talk about that. It's a bit of a stumbling block in our project to date. And then we also interviewed key informants, and these were experienced OBOT providers from the adult world, including physicians, nurse care managers, and behavioral health specialists, as well as primary care providers of youth who are coming from areas of high opioid use disorder prevalence, who may not already be providing this type of care. And here we've completed enrollment because we reached thematic saturation pretty early after we interviewed 13 key informants. So I'm actually going to start with the key informants because we've actually completed this analysis, and so the findings are better organized. So for each key informant, among the key informants, we've identified barriers and then sort of principles of care for adolescents and young adults. So I'm not going to go through every one of them, but we can come back and talk about them to the extent that they're that these sort of quotes and these themes are helpful. But one barrier that rung true was that our traditional models of healthcare and engagement don't resonate with adolescents and young adults. And a lot of these slides say young adults because that was sort of the framework from which many of our key informants were speaking. But strictly speaking, we're also interested in these same issues for adolescents. And so the principle of care that really emerged as a theme was we need to meet young people where they're at, consider insurance barriers, navigation, mobile support, and thinking outside of the hospital environment to build relationships. And so this key informant said, I don't see them at my main campus at the hospital because that's a pediatric clinic and that doesn't feel right for them. And then also a lot of them don't want to do methadone because they're dealing with a population that may have been using for 20, 30, 40 years. And that's a really different population. So having them be seen in an environment that's not with pediatrics and they're not with people that have been using drugs for 40 years. And so what you see is something that I think a lot of people on this call know, that adolescents and young adults really fall into this gap where their pediatrician doesn't want to treat them or doesn't feel comfortable treating them in a practice that's caring for like little babies and cute, cuddly kids. And yet the adult world is also not appropriate for them because people have been often injecting and using opioids for decades. And so they really sort of fall into this gap in care. Another barrier is that youth have multifaceted lives and other responsibilities really kind of infringe on the demands of their life. And so what we really learned from our key informants is that we need to be flexible. We need to have extended clinic hours. We need to think about getting outside of our traditional location. We need to integrate our treatment into the daily and weekly schedules of youth. And I'm actually happy to report that with the advent of telemedicine, this has actually become a lot more common and easy. It's pretty frequent that we will, like, a young person who's working their job will, take a break at the time of their appointment, go out, sit in their car, and then do their clinic appointment from their car while I speak to them by telemedicine. And so we're finding ways to make this much easier. And so we typically, here's the quote here, we typically in an office-based setting have structured visits that happen at a certain hour and certain days of the week. I think that for adolescents, if they make it to the clinic an hour late or even the next day, that we need to have more of an open access model, which can be really hard to pull off. But I think that for any patient that walks in the door, the last thing you want to do is send them away for any reason. I think regularly scheduled visits for an adolescent with an opioid use disorder are going to be hard, to manage. So even having an open access model is one other suggestion. So here you see this key informant saying that, like, hey, visits and appointments in the traditional sense may not be the most effective way to do this. We should be thinking about, are there other ways that we can meet people where they're at on their own schedule and sort of allow for walk-ins. I'm going to skip this slide, but could come back to it. This is a slide sort of around the expectation for abstinence. I'm going to skip this slide as well. This is around sort of co-occurring psychiatric conditions, which are really very common, as many people on this call know, in youth with opioid use disorder. I'm going to talk here about parents. Key informants here really highlighted that parents can be either allies and or sort of fraught in the treatment of young people. And we need to make sure that we have parent-specific services and supports, including parent education and their own sort of involvement in the direct care of the young person. So here's a quote from a key informant. Well, they, parents, need to be educated about it and to stop feeling that everybody needs to get off medication and understand the disease. So we need to do a better job at educating treatment and on the disease and on the different treatment modalities and what's more appropriate based on the evidence, because we departed with them because they're sending different messages. He's not going to stay. He's not going to do well. Is he going to go off treatment? Then that's going to happen. So we need to partner with them. I think you would work with them, with counselors and therapists, to try to sort out the family dynamics. You have to find a way to get the family dynamic in order to help that adolescent. So there's a lot in this one quote. Some things that really emerge here for me is that you can hear a key informant almost like speaking with frustration around the stigma or the concern that parents have about medications for teens, that despite their efficacy based on clinical trial data, despite the fact that we've just reviewed that they seem to help retain youth in care, and despite the fact that we know that they treat cravings and withdrawal in young people, parents really often are averse to putting young people on medication. And then you see here this sort of call for having a multidisciplinary approach to helping sort of treat the entire family or support the entire family, not just the young person. I'll skip this slide, but it really was focused on peer involvement and support for an involvement of peers in the recovery of a young person. And I'll skip this slide here because we hear it in a moment from the youth's perspective. So I'll try to move through these quotes relatively quickly just to make sure that we have time for our discussion, because these quotes get a little bit long and I won't go through every of them. But I think when we asked youth, what is it that we need to be doing to improve addiction treatment for you? Here were some really interesting quotes that we haven't really sort of formally organized into themes and sub-themes yet, but I think have some important lessons for all of us. So here's a young person who said, it's hard for teenagers because they already are going through so much change and they're insecure and don't know who they are. I don't know who I am and I'm 24. And a lot of them didn't live normal lives. They just grew up and started using. Like I started using at a very early age. So I didn't really do teenage things. Like I didn't go to parties and I didn't hang out with friends and didn't really go to the beach. So I think maybe doing things with teenager that they might not have a chance to do, I think is a good idea. Like they've already grown up so fast due to their addiction that I don't think being in recovery, they need to be pushed up to grow up even more. I mean, it all depends on age, but I remember being in treatment as a teenager and being treated like an adult. It's not fair because they're not adults. So this is really interesting to me because it's a young person actually recognizing sort of their own developmental stage and the developmental inappropriateness of the adult-focused treatment that we often put young people in. A similar quote is this one. I felt a little bit out of place in treatment because I was in every single one, I'm the youngest one. Everyone else there was like usually 30, 40 and up. I related to everybody there, but I always came away and just felt ashamed kind of because I'm always the youngest kid that came in. So like I never went there and there's never been a kid my age. I just feel like, why aren't there more kids my age? Am I the only kid that realizes I have a drug problem? So I think it would be more helpful. It would have been nice to be around people my own age. And so I think this matches up to something that we really know, and that is that young people want to be with other young people and not with older adults when they get treatment. And I think often we put 18 and 19 and 20-year-olds in treatment with 40 and 50-year-olds in many places across the United States. Here's another quote from a young person. I think that maybe they spend more time not learning out of, actually, I'm going to skip this one and move on to the next one. I just started with my sponsor. He actually makes recovery for me, like enjoyable. Like it's not all serious and awkward like a lot of the older ones. He's kind of younger and I relate to him and the stories that I've heard and talk about. And that's why I chose him. I never did the sponsor thing before, but it's helpful because I can relate. Like we'll go to a meeting and listen to the music, bump the music all the way up. Like I feel like it's a friend more than a sponsor. And then like a friend, you have more trust. You get more out of it because you're more comfortable with the person. So this is an interesting comment because you can really see that this young person has strongly related to another young person who's supportive in their recovery. I think this is an important key point because you can see the relation that's developed here. And yet on the other hand, you would probably hear a lot of substance use providers say, well, hey, this is like somebody who's meant to be here for support for you. They're not your friend. And so you can understand that there's a tension here that when we think about the supports that are available to young people, we need to make sure that that person is stable and in recovery, and yet may also be able to relate better to a young person by virtue of they themselves being young. And here's a young person. I'll summarize the quote that says, basically, this young person wants to have support 24/7, recognizing that a doctor's office is not going to be able to answer necessarily, the middle of the night call and provide good recovery support, but that often if you have a recovery group or recovery sort of coach or other support that you can turn to, that can be really helpful. So then we have a few quotes from caregivers that I want to go through because I think they're really helpful. And then we'll wrap this up and move on to a brief discussion of my AIM-3, and then we'll have time to talk as a group at the end. I've left lots of time for discussion. Here's a caregiver. Again, these are not organized into themes and sub-themes yet because our analysis is ongoing. But this caregiver says, one of the things that we liked a lot was that it was a coordinated care effort for the psychiatrists and the physicians and a social worker. So this is talking about our addiction treatment program that has sort of an integrated model so far. Reporting to us was a social worker who was assigned to the parent, and they all talked to each other. We'd been through, at that point, probably 17 other programs, which, I mean, can you imagine as a parent being to 17 different treatment programs? Some residential, some outpatient, and we've never experienced anything where everybody talks to everybody else. And we did not have to, as parents, we didn't have to reinvent the wheel every time something happened to try to figure out how do I get that message to the right person. We had one person and they conveyed it to all the people, so that helped a great deal. We did not feel as parents, nobody was coordinating their daughter's care. And so here they're talking about other treatment programs they've been to. This parent is saying, nobody talked to each other and we had to bear the burden. And every time we had to start something new, we had to start all over again and tell our whole story and say what we did and what did and did not work and nothing worked. So, and we were out there in the wilderness by ourselves, it felt like, as a parent. And so you can see the frustration that parents with all these different treatment programs, all these different interdisciplinary providers, all these different sort of intakes that they've done, telling their story over and over and over again, only to then transition to a new place, that this is a big burden for families, and that to the extent that we can bring care together and talk amongst ourselves and take that burden off the parents, that's a big help. I'll skip this series of caregivers comments, but we could come back to them if you like. Here's another one. Even if a kid is over the age of 18 to 21, they're still a kid, and it doesn't help to put them in with 30 and 40 and 50-year-old drug addicts. And this is the word of the parents. I don't use that language myself. It's a whole different world when you're an adult. My daughter has a lot of gifts. She's artistic. She's creative. She's all the good parts of ADD as well as the bad parts of her ADHD that she has. And it would be really wonderful if she had more outlets for those things, but her depression and other things get in the way of her expending a lot of energy. But I think, and maybe for people of any age to have an outlet where it's not 100% all the time just about your substance use, but it's like, what else is there? And so a couple of themes here. Again, you see this difference in age coming up, but then also this idea that recovery is more than just, not using substances. It's, about finding other aspects of life enjoyment and the things that you care about. And that really comes up here in this quote as well, which says, somebody whose job it is not to focus on the substance use, but to focus on the rest of what's going on inside you and what you can contribute to the world in a positive way. If my daughter had somebody like that, I think her life would be very different because she won't accept that from her parents, but maybe she could accept that from somebody who could help her find the art teacher that would change her life, or the person who will help her write her short stories that are really wonderful and funny and creative, but then not just leave them under her pillow, but do something positive with them. That's what she needs, quite frankly, that she needs someone who's a life coach, who's looking for the positive parts of her psyche. I'll skip this one and this one. So just some really interesting findings that you can hear from youth and caregivers about what they want out of treatment. And you can see that it's just miles away from our traditional addiction treatment models and also miles away from our traditional primary care-based models. And so here, aim 3 of my K is to really actually start to incorporate some of these clinical changes in order to improve our own clinical services. So at Boston Medical Center, we actually have one of the nation's first primary care-based addiction treatment models that uses this OBAT model for youth. So we actually have pediatricians, one of whom is me. The other one is Dr. Sarah Bagley, who many of you know, who are actually doing pediatrician-based primary care-based addiction treatment model, addiction treatment for substances of all types, including opioid use disorder. And we have an integrated care model where we have a nurse who is helping to support us in our work. We have also other supports that we've built out over time, including behavioral health integrated in our own setting, from social workers who are doing counseling. We have recovery coaches. We have a psychiatrist, actually 2 psychiatrists that we have access to. So we have lots of different things that we can do with this treatment model. And we're trying to figure out, what is the best treatment model for primary care, recognizing that not every treatment program is going to have an integrated behavioral health model. Not every treatment program is going to have psychiatrists that are available. How do we sort of do what's best for patients and for families while also recognizing that this needs to be a model that can be transportable to other lower resource settings? So Dr. Bagley has a paper that has been accepted for publication and should be out soon that just describes the baseline characteristics of our clinic. Our clinic is called the Catalyst Clinic. Catalyst stands for somewhere in there is adolescent and young adult and substance use treatment, all sort of melded together into an acronym. But we have the baseline characteristics of the first couple of years of our program, in which we treated 148 adolescents and young adults. You can see that we have a number of patients who did not have opioid use disorder. Some, had marijuana use disorders or vaping difficulties, nicotine use disorders. And so those youth tended to be younger. And so the mean age at first visit for youth without opioid use disorder was 19, whereas it was 22 for opioid use disorder. So you can see that really we have a much more young adult population in our opioid use disorder track. You can see that the majority of our patients are actually males, although in our opioid use disorder work, we actually have a higher percentage that are female. And actually, these are categories as mutually exclusive. Since we started the program, we actually have had a number of trans patients and gender non-binary patients that have come to our practice as well. And so we're starting to provide gender management services for our patients as well. Most of our patients are primarily English speaking, and most are white. Although outside of our opioid use disorder work, we have a number of patients who identify as Black and Hispanic. Most of our patients have public health insurance. You can see that the rates of co-occurring behavioral health disorders are really high in our patients. A large number have depression, anxiety, and or ADHD at the time of presentation, or another mood disorder or PTSD. And these are the baseline characteristics. Often what happens is as we get to know patients more and do sort of ongoing screening, it's clear that they actually have many other comorbid mental health conditions. And then rates of other opioid use disorder, or of other substance use disorders, are quite high. You can see that in particular among youth with opioid use disorder, there is just a really high percentage that have nicotine use disorder. About half have nicotine use disorder overall. And so it's clear that we have to do a lot around smoking cessation and vaping cessation. And then in our program, 90% ultimately were prescribed a medication for opioid use disorder. The other 10% were not for various reasons. And so in this trial in which we're looking to do sort of improvements to our clinical model, and then in a quality improvement way, sort of seek to improve our services, the outcomes that I proposed in my K23 and that we're asking families about include a mix of implementation and then OUD treatment measures. And so the implementation outcomes that we're interested in are feasibility of the model, acceptability of the model, fidelity of the model, and sustainability of the model. And then OUD treatment measures include retention and care, and then relapse at 1, 3, and 6 months. But then, of course, there's all these other outcomes that we're interested in understanding for families as well: patient satisfaction, rates of HIV and hepatitis C testing, rates of PrEP delivery, Narcan prescribing rates, mental health referrals, recovery coach engagement, receipt of medication, durations on medication, family function, self-efficacy, coping skills, housing, education, employment. So just all of that are things that we're interested in learning about and hearing about from families. So with that, I'm going to stop and make sure that we have adequate time for discussion. I would love to hear your questions, and then also your recommendations for a junior researcher, in his 3rd year of his K, starting to apply for other things and starting to wrap up this K23 and my 3rd aim. So thank you so much.
Thank you, Scott, for that outstanding presentation. Your work is very exciting. Any questions or comments for Scott?
It's George, Jose. I just make a comment. The stigma, a lot of times we talk about stigma, keeping people from prescribing or accepting opioid medication. It might be better to think about it as like an adverse effect of the 12-step movement. It's like any drug that has effects. If it doesn't have side effects, it oftentimes doesn't work. And the 12 steps were developed at a time when no medications were available, and that no medication thing was very, very relevant at that time. But things have changed, and there's a time warp going on in a lot of people's minds. It's been very ingrained in many people's minds. So I just throw that as a comment. I don't know if other people agree with it.
George, I have a comment on that. By the way, Scott, thanks for that great talk. Very, very helpful. George, I agree with you that there is some influence of the mutual help movement, but I also think there are developmental issues with young people that transcend the message of AA, NA, Smart Recovery, others, having to do with things like, I'm invincible, I feel good today, I've got this, what's your stinking medicine for anyway? No different than young people might reject insulin for their juvenile onset diabetes, where there's no message from mutual help telling them not to take it. It's just, what are you bothering me for with all this doctor trash? I've got this. I feel good. Leave me alone. And besides, it's none of my mother's stinking business either. So I just would add that perspective.
Sure, I agree. It's not multi-determined, but it's several factors.
Yeah. I found it interesting from the quotes you read that of the parents, and my interest is in families, is that the quotes came from parents who were relatively well differentiated from their children. So, they sort of had a perspective, and they were talking about what the system needed to be helpful to their child and incorporate them. And so it seemed, I wondered if the parents that you were not able to involve were the parents that we call enmesh with the kids, the parents who are overly involved, who are in conflict with the kids, were not able to achieve that level of separation and view the child as their own person. And so if that's the case, it may be interesting to talk offline about how do you get those parents involved.
Yeah, I would love to hear your thoughts. We have just really struggled in our recruitment of caregivers. And we actually worked with NIDA to loosen our inclusion criteria to be able to talk to parents from outside of our program in order to sort of get new perspectives and broaden our recruitment pool. And it still has been a challenge, but their perspectives are so key. Because their involvement is so, in some cases, in many cases, just really beneficial to the outcomes of the young person. And then in other cases, it's really detrimental having their involvement, or at least not being able to work with them to figure out how they can work to improve the treatment outcomes. But we're struggling to find those parents. And we tried everything Twitter, Facebook, special recovery groups, parent recovery groups, just, all over, and have really struggled to get parents to come in.
Scott, this is Lisa. Thank you. That was such a terrific presentation. Your K work is just remarkable. I just love all three of the aims. They fit together so beautifully. I've been following a lot of your many recent publications, including the one you mentioned in the JAMA Pediatrics and others you published in Pediatrics and elsewhere. It's just such a rich contribution to the literature, and it's just really innovative work you're doing with the K. So congratulations on all that you're contributing and learning. It's just incredibly important. I wanted to ask you about that. You have this really, remarkable program, the Catalyst program that you described. And I was wondering, what trends have you seen? I've been very curious about this. What trends are we seeing with youth and youth substance use in the last year with the pandemic? And as actually also as part of the broader sort of opioid epidemic, but, in terms of vaping, in terms of opioid use, in terms of other substance use, and of course the intersection with mental health. But I was just wondering what you're seeing, given the breadth of young people that you treat. It would be great to hear your thoughts about that and what you're seeing in your clinic.
Yeah. So, bearing in mind that I'm not speaking from an epidemiologic standpoint. I'm speaking from, the guy who comes into clinic on Thursday standpoint. What I am seeing is, and thank you, by the way, Lisa, for your really kind comments. That means a lot coming from someone as incredible as you. So we're definitely seeing the broader trends that are taking place in the sort of overall national overdose crisis, almost irrespective of COVID, in that we're seeing more and more stimulant use disorder. That's really becoming more commonly comorbid with our opioid use disorder than ever before. And then also a lot of standalone stimulant use disorder, which is very new for us in Boston. I know that out west and in the Southwest, that's much more common, but here that has not been common to date. We're definitely seeing a lot of vaping. The vaping has been so interesting for me amid COVID, because vaping was this steadily increasing problem. And then, in the fall, all of a sudden, we had all these cases of severe lung injury, and we had this huge influx of families just panicking. It really was a health scare, including for a lot of youth. We tend to think of health, scaring youth about potential health problems from their substance use as being a very ineffective and potentially backfiring way of motivating youth to change. And yet something about this lung injury really scared a lot of youth. And we had a lot of youth and families come in. And then COVID hit, and we actually had a ton initially of vaping telemedicine that we were doing, because it was like the kids that were vaping, but vaping at school and elsewhere, but were really vaping a lot of nicotine, all of a sudden we're at home all the time and going into withdrawal. We actually saw that presentation a lot. And then now that COVID has kind of gone on for, at least a year now, we actually are not seeing a ton of vaping. It's almost like, a lot of kids put it down because they were home all the time and couldn't vape. And so things went quiet for a while. So it's just been a roller coaster ride. From the opioid use disorder standpoint, I worry a lot about the drug markets. Are people, the people that they got used to buying their substances off of, are they still able to find, or were they still able to find that person? And when they couldn't, who did they turn to? And what did that mean for their drug supply and its safety? I worry a lot about people's access of harm reduction services. I worry a lot about people getting access to treatment when entire health systems have been completely reshaped. And yet, on the other hand, there's enormous opportunity, because now through telemedicine, I'm able to provide addiction treatment to somebody on the other side of Massachusetts who never would have come into Boston before to see me. So it's again like a roller coaster ride in so many different ways.
Yeah, thanks so much. That's fascinating. I have one more quick question. When you have young people come in for treatment, are you heavily seeing that they're using fentanyl or fentanyl products, or are some coming with sort of pill use at this point?
We're not seeing a lot of pill use.
No, I didn't think so. Yeah.
Yeah. To the extent that it's pill use, it's like pill use in that we just have, our markets are flooded with counterfeit fentanyl containing pills here.
Yeah. Yeah. Thank you.
So Scott, this is Geeta. Once again, delightful presentation. I always enjoy your presentations and your work. So keep up the hard work. I'm going to sort of ask you to just speculate, if you were to develop a ideal program that's set within medical setting, primary care or adolescent medicine or some such program, what would you think it would take to get these people to show up? Because we know there is still opioid use happening at a pretty high level in this population. So how would you design it? What do you think are the ingredients that would probably help attract and keep these people?
Well, I'm going to shoot myself in the foot as somebody who's written a K around primary care-based addiction treatment, but I actually don't know that it's the model for youth. I think it's worked well for adults, or for many adults. I actually think for youth, we need to be out in the community more. I think we need to have storefront access. I think we need to have mobile access. I don't think it's coming to an academic medical center like mine, where you have to park downtown and go into the big hospital and ride the elevator to the 6th floor and check in. And I don't think that's what it looks like. And as much as I would love for every pediatrician across America to just treat opioid use disorder just like they do ADHD and other sort of comorbid mental health conditions, I don't think that's the solution right now. I think we need to do so much upstream workforce education, starting in medical school and residency. I think the pipeline of development is going to take at least a decade. And that's even probably overly optimistic. And so I think it's actually probably going to be subspecialists like many of the people on this call. And I think it's going to be models like Mark's, where, you're like going to the young person's house with your naltrexone shot and giving it to them. I don't think it's going to look like a come to us. I think it's going to look like a we come to you kind of model.
Right. So I think, Mark's doing some great work with all this mobile and ambulatory care. But I'm talking about the access to these people, to get them in the door. Where would you find them? And I'm glad you are being very honest about probably primary care not being a good fit, and that perhaps it's a model that may not work for this particular age group. But how about ED? Would that be a setting where you could possibly find these people? Are they showing up in EDs? Or what sort of community settings do you have in mind?
It's a good question. We've been talking a lot to our own ED and other EDs, and we're actually still finding that the volume is still pretty low. That many youth are not making it into the EDs, even when they overdose. They're really resilient. Actually, many youth don't overdose to the extent that older individuals do, and they have lower mortality and lower hospital admissions rates. And so, yes, many youth do come to the ED, but I don't think it's the primary place to find people. I think, sadly, right now, our best referral source is letting the detoxes know about us, because youth and families out in the community still think, oh, when someone has a problem with drugs, you take them to detox. And that's where we're getting most of our patients right now. But I'd like to take detox out of the equation and have them come to us. How we do that, Geeta, I don't know, and it's noon.
Yeah, right.
So
No,
I'm going to take the prerogative of asking you the last question and follow up on Geeta's question. We usually think of getting patients where they are. And so if patients are in the primary care setting, that's where we get them. If they're in the emergency department, that's where we get them. And so where is the flow of these individuals? Where are they as a group? Where's the flock?
Yeah, well, some are homeless and living on the street, and so we've got a mobile van that we partner with to do outreach to them. It actually hasn't had the high volume that we had hoped for. There are other opportunities too, I think, in partnering with colleges potentially. So I see Kelsey says school settings. So, but that's, I think, going to get sort of like your upper class educated youth, and is going to miss a large number of young adults who are entering into the employment workforce. So workplaces is another option, but that's, really scattered. Youth are working in settings all over. So that doesn't make it sort of readily easy to target. And so I don't know the answer to that, Jose. I think, unfortunately, many youth who use are doing so in private settings where we don't have access to them.
Scott, it's George again. To what degree do the reimbursement models support this integrated care? Because you get into psychiatric medical things, you're talking about higher level people, higher trained salaries. Compare that with addiction counselor who's trained in 12 steps, much different economic situation. I'm curious. I have a little anecdote about what the VA did with that, but I can save that for later. Yeah.
Our reimbursement model has been largely sustainable because we, first of all, we have physicians that are able to do this work pretty quickly because we're specialized, and so we're pretty efficient. And so we're able to bill at a pretty aggressive level for what we do. Our nurse also is doing a lot of high sort of flow patient population level management, and is billing for a lot of the care that she's delivering and the counseling she's providing. We're also able to capture our telemedicine visits as well. And so it has been a sustainable model, but I think that really relies on having people who can do this work sort of quickly and effectively. And that's where the training comes in.
Thank you so much, Scott. We are over time. We're all excited to ask you questions. Congratulations on your terrific work, and we look forward to hearing more about it as you progress. Thank you, everyone.
Thanks so much. Nice to see everyone.
Thank you.